first of all, when we look at contact precautions, we see that it says gowns, gloves, dedicated equipment. Dedicated equipment means everything in the room should be disposable. Everything in the room should be disposable. You may or may not know they have disposable stethoscopes. When that patient's gone, it's trashed. They work, but they're disposable. It's to prevent the transmission of infection due to something called a fomite. You better know that word. Fomite is an inanimate object that transmits infection. As we said earlier, this is your elevator buttons, this is your side rails, this is countertops, this is the television remote control, this is the gown of the patient, this is the call bell, it's the doorknob, all the things that all of us know can really harbor infection. And RSV and C. diff and different things like that can stay on these surfaces for hours and even days. So when you touch it, you have this propensity to get it, okay? Now, the skin conditions is the heading I use for contact. It's one of the ways you're going to remember this. If it's a skin condition, it probably needs to be under contact precautions, but please be careful. Please always be educated about certain skin conditions that have absolutely no contagious ability at all, like psoriasis. It looks horrible for the patient. I'm sure they're very much feeling some kind of way. But if you put gloves on to do a blood pressure, that's stupid. Okay, it's psoriasis, for crying out loud. Okay, it's not contagious, you know that. But there are some very contagious conditions under here. Impetigo, for one, is one of the most infectious skin conditions for the preschooler. And the infectious diseases in the nose and the mouth area, under the chin, I should say above the chin, under the bottom lip. And you'll see this as like a honey-colored, crusted vesicles or pustules. You probably want to put the word pustules. I really need you to know your lesions, okay? This is honey-colored, crusted pustules. Very infectious, super infectious. Preschool, you see it. It doesn't have to just be isolated on the face, but 99% of the time it is. Okay, so impetigo is really serious. Lice. I have a fascinating, wonderful patient whom I delivered her children, I don't know, 4 or 5 kids. And she is probably, right now, a millionaire of some sorts, because she opened up a local company. She's been on television repeatedly to literally pick the lice out of kids' hair. So she got this idea, and you would agree, none of us want to do it. So she came up with this novel idea to open up a company who does natural defestation of this lice from these children's, scalps. And she's probably on her 2nd million by now. And it wasn't that long ago, because I just delivered her baby not too many years back. Lots of babies. Okay, so, this is America. You do whatever you want. You get a quick million if you came up with the right idea. Now, so lice, of course, loves clean, dry hair. Many of my students have the misconception that this is the poverty-stricken, dirty, oily-haired kid. No, the hell it ain't. This is the child with very clean, squeaky clean, dry hair, and it is so contagious. Obviously, we're trying to check the back of the neck, behind the ears for this infestation. We're going to throw away things that you can't wash. Things that you can wash, you're going to have to make sure is in very hot water, hot dryer. These are things you have to know. Hint, hint. For the child that has lice, we know that they're going to need 2 treatments. 1 treatment's not enough. They're going to have what we call nits on the hair, which is basically eggs. You feeling itchy yet? Yeah, a little bit. Okay, so the nits are very often removed with like a fine tooth comb dipped in vinegar. And obviously this is why you're recording, because things go fast today. Cellulitis, OMG, cellulitis. Cellulitis is horrifying. There's a wonderful picture on my picture board of cellulitis. You will notice on the board this very inflamed foot, and the cellulitis in this picture was caused by MRSA. And it is bad. I've diagnosed it a million times. It's not that uncommon. It could start as a bug bite. It could easily start as a mosquito bite that gets picked with dirty nails. It could end up being from the locker rooms. If you played soccer, we had a young lady that was very good at, I think, soccer, or maybe volleyball. I can't remember which one. But she shared with us that she had it, and it was horrible. Okay. You could have chicken pox, scratch an open lesion. Just really not that hard to get, especially since MRSA is pretty rampant. Okay, so cellulitis is horrible, and it's weepy and oozing and leaking fluid. It's wet. You have to change dressing 3 or 4 times. Oy. And if you're not careful, we can become septic, and we could actually get some gangrene and necrosis, some osteomyelitis. You got to think deeper what your role is in this patient. Yes, doctor?
Just to comment on that, a few years ago, the NFL had a big breakout with cellulitis.
They did.
From the locker room.
From the MRSA.
The MRSA athletes.
Here, right here, too. Yeah. We have had 2 athletes die from this, and it started as an MRSA infection. It went to cellulitis. It spread out to sepsis. They're in the hospital there with septic shock. Okay, one of them had already gone through the whole necrosis, gangrene, amputation. This is athletes. Okay, so none of this stuff should be taken too lightly, huh? Okay, God forbid the patient's a diabetic or immunocompromised, it's going to take off like crazy. Always remember you have the potential for cellulitis with phlebitis. As you take care of this IV and you monitor it every hour, you're looking for any kind of sign of infection or phlebitis, inflammation. Phlebitis is just inflammation. Okay, scabies, oh boy. Lord Jesus, help me with the scabies. By this point, you should be itching a little bit. And then when we talk about scabies, it should just be closed off, scratching, okay? Now, so scabies is so bad. Because if you work somewhere, and lots of you have already, where there's a scabies outbreak, and I will say there's an institution in the city, I always refer new nurses to go work there, that does it the best. They follow the guidelines all the way through. But I'll tell you something, with scabies, the managers got to track back 30 days for anybody that touched that patient. They've got to call the agency nurses up. They've got to call physical therapy up. They've got to go ahead and call respiratory. They've got to call everybody and get them treated. 30 days. Scabies is like, it's an infestation where you see burrows between the fingers. They can be brownish, red, even a little black. They're called burrows. They're between the fingers, between the toes, and the wrinkles of the skin, with the homeless population and the long-term care facilities being at risk. Even our military are at risk. Who can tell me which branch? Not the Army. Navy. Why? Close quarters on the ship for 9 months at a time for their tour of duty. So this is like gonna spread like wildfire. And it's contact precautions, so it can spread through the blankets, everything. And they're very active at night, so the patient's going to really be miserable. This is similar to lice in terms of the treatment. We like to use a permethrin cream, but we don't have to treat scabies twice. We only have to treat it once. So we only treat scabies once. Lice needs 2 applications, about 7 days or 10 days apart. Open oozing wounds. OMG. So Dr. Jones knows that his experience has been wound care, wounds out the yin-yang, and we have a rule, and the doctors always want you to remember it, and that is, if it's open, if it's oozing and weeping and draining, it's probably infected. And it may be infected with some really resistant organisms like VRE, which is your vancomycin-resistant enterococcus, or MRSA, methicillin-resistant Staphylococcus aureus, or some other outrageous infectious disease that takes a lot of work to get it, to get it under control. And what happens with these open oozing wounds, they can take forever. Dr. Jones, what was the longest you told me with your patient? It was a year, did you say? Longer. Oh. Diabetic, immunocompromised, more than a year. And lead to amputation. Put your gowns on when you got to go in there and do dressing changes and the wound is draining. These are things you don't see happening with your friends, your colleagues in the field. You can't be that person. You can't take this home to your families. Your child, ooh, grandma, ooh. Okay? All right, conjunctivitis. Oh, that's simple, that's pink eye, right? So pink eye is actually contact. Now, of course, preschool, grade school, grown-ups, doesn't matter. Everybody can get a little pink eye. It's not to be confused with allergic rhinitis or, allergies. It's not the same. Pink eye, you wake up and it's all gooped and crapped and draining and ew and yellow, crappy stuff in your eye. It's very contagious. It's very contagious. You already know that. Has to be treated. There are two types. They're both contagious. One's viral, one's bacterial. Herpes simplex virus. Ugh. There are two types, correct? You have herpes type 1, which is in the form of a cold sore. And this is still under the contact guidelines. Which kind of guidelines would you put genital herpes under? Yeah, it's standard. Unless you go in there sleeping with your patient, I'm thinking you're cool. But no, that might happen. I hope not in this core group. But if you have the cold sore, this is so bad. If you touch it and you are to touch someone else, again, contact, then they're at risk. Certain people are more susceptible to cold sores than others. The cold sore itself is not an STD, it's a cold sore. And what we say in this situation, we do not, and I've had to send people home as a charge nurse, we do not let you work with mothers and babies when you have an open cold sore. We say, okay, sweetheart, you have to go home for the day. Because the OB patient, the maternity patient, the newborn, all of this, they can't handle it. Okay, it's not appropriate. So you can't work around mothers and babies. And you can't work in antepartum, which you have to know those terms. Antepartum means you're still pregnant. You can't work in postpartum, which means you just had a baby. You can't work in intrapartum, which is labor and delivery. You just can't do it, period. Okay? The next category of crazy is called ABCs and 1, 2, 3s. All that means is that this is what we abbreviate as nurses and doctors. We use these abbreviations all day long. Our patients hear them. They have no idea what you're saying. But we're not about to say on a daily basis, methicillin-resistant Staphylococcus aureus. We're just not going to say it. So we just abbreviate things, right? But you do understand there's no abbreviations typically on any test. No matter if it's a PA exam or nurse practitioner, they don't tend to abbreviate. So you have to know the full names. So the first one is probably more common to most of you, MRSA. As Dr. Jones said, this has been seen in athletic arenas, the locker rooms. Oh my goodness, wrestling. Wrestling mats, come on. Just think that one through. So we have seen this in locker rooms. We have seen it with our wonderful athletes. We see it with wounds, pressure ulcers all the time. I could not believe it, but I had a very stubborn mastitis. One of my patients had a very stubborn mastitis, and I was treating it appropriately and following all my CDC guidelines, and it was still driving me to drink, and it was driving her even crazier, because mastitis is super duper ridiculously painful, and she's still trying to nurse, because as you know, we don't have to pump and dump with mastitis. You can still nurse, but it was resistant. It was just like really driving me crazy. I said, you know what? I'm just going to culture it. I couldn't believe it. MRSA. In the breast? What? So I cultured the breast milk, sent it off. There we go. So I had to get an infectious disease consult. Yeah, that was weird. Now, it can be in the urine. You guys know that. It can cause a UTI. Absolutely. It can cause some respiratory problems. So you can culture it out of nasal drippings. So this is not, you know, what you want to deal with on a daily basis. So what would I treat that with? I want you to think it through. If it's methicillin resistant, we know doggone well we can't use what? Penicillins. We cannot use penicillins. And which drug category has a cross-reactivity to penicillins? Cephalosporins, so we can't use that. That would be silly. So what's the next category? Because it is an order or hierarchy of antibiotics. We can't use the penicillins, which by the way is on your medication packet in order. We can't use cephalosporins, that's the second group. What's third that we could use? Aminoglycosides. And what do those end in? Mycin, except for erythromycin or clindamycin or azithromycin. Those are not, absolutely not aminoglycosides. Those are macrolides. Be very careful not to include those three in your aminoglycosides. What did you have to know about aminoglycosides? They are ototoxic, which means ears, and nephrotoxic. So what did you monitor before you ever thought about putting it on a patient with diabetes? Be careful. Think it through. I said before you hang it. BUN and creatinine. What do you monitor while it's running? Peak and trough. Be very careful with separating those two out. Many, many students erroneously will choose peak and trough for the first question I ask. This is why I told you when questions have things like before or after in them, stop what you're doing and think it through. Because if it's before I hang my dose, there would be no peak or trough. How the hell would be a peak or trough? There's nothing there. So it has to be BUN and creatinine. In other words, beloved, you're watching kidney function. Really, really watching it with this patient. So in essence, what am I saying? I'm saying that all MRSA patients need to have kidney function monitored because the only thing we usually treat it with is an aminoglycoside. So you could extrapolate that without having the knowledge about the aminoglycoside. Just make sure you know that MRSA is probably going to be treated with that. Okay? Now, Mdro. What in God's name is that? Multiple drug resistant organism. It's an umbrella term. Multiple drug resistant organism, an umbrella term, is going to include infectious diseases like MRSA, VRE. It's going to include those. So multiple drug resistant organisms. It's just an umbrella term. Okay, I can't say, oh, the patient in room 3, you know she has that infection, Mdro. No, no, no. But I can say that we've gotten a lot of patients lately that have Mdros, nurses. So we're going to have a seminar on how to prevent these nosocomial type of infections, because some infections are hospital acquired. And remember the rule. Medicare will not pay for infections or conditions or accidents like broken hips from a fall. This has happened a lot. They will not pay for any of those if the patient was not admitted with it, because they're very preventable. So if your patient didn't have a UTI on admission and they got one, that's your fault. That's our fault as the healthcare team. And if that's what's happening, Medicare feels strongly, get your life together. We're not paying for that. My nurse, and I think it's poignant to point this out because not everything is our fault, but it will be something that they may not pay for. And the week that she came to talk to you, my nurse had a patient that got out of bed and broke their hip. She came from this class, so she covered her butt. She not only documented that she taught the patient not to get out of bed without assistance, and by the way, she was being more cautious than the average nurse because that's what I teach you. There was no reason why the patient could not get out of bed. There was no kind of compromise in their musculoskeletal system. The reason why she did it was she felt strongly, here you go, that all the IV lines that they had could get trampled over. So she said, you know, you're on a lot of stuff. I want you to call me before you get out of bed. What happened in that instance? Number one, the patient heard her. Number two, she documented it. And here's the catch. Number three, the aide was in the room. You didn't have to make sure your aide's in the room. It just so happened that the aide was in the room. Literally, the patient got out of bed, climbed over the side rail, and the side rail was something that was allowed to be put up because the lady had signed the consent for it, and she trampled over the lines. She broke her hip, y'all. So, of course, now this nurse who called me is very scared. And we went over, what did she do? I said, honey, you didn't do anything wrong. You literally did more than most. She said, but my manager, she's mad. She's looking at me crazy. You know, I've only been here a year, blah, blah, blah. I don't care what the manager's doing. You did what you're supposed to do. Well, you know, I had to do the incident report and risk management wants to meet with. That's okay. You did what you were supposed to do. So she met with risk management and they said, excellent job. You did a really good job, better than most nurses. And the wonderful thing about the patient is they had integrity. And they said, she did tell me not to get out of bed without calling her. Did that hip care get paid for? Nah, not so much. Not so much. It doesn't negate the fact that the Medicare is not going to pay for it because they didn't come in with it. Okay, so you got some rules to follow on that. All right. Now, VRE, vancomycin-resistant enterococcus. Uh-oh, wait a minute now. Did I just say vancomycin-resistant? Oh, God. Wasn't that our third tier of drugs that work really well when things are resistant? Oh, okay, so wait a minute now. If vancomycin doesn't work, what else won't work either? Cephalosporins or penicillins. Oh, I think you better know that. Yeah, you better understand that with VRE, aminoglycosides, cephalosporins, penicillins aren't going to do anything. Uh-oh, so what we're going to do, y'all? Bactrim. Now we need to go on over here to the sulfas. Pull one of those. Bactrim would be our drug of choice here for most people, except there's a strong allergy to it, so you have to be careful. As I noted earlier, VRE is found in urine. It's found in wounds, surgical incisions. It's really bad. It is so hospital acquired. Here's how bad it is. 75% of all ICU patients or more have VRE. 75% of all ICU patients or more have VRE infection of some sort. It's a given. So you had to know that. You had to understand that the ICU patient is a very special patient, and yet they have this exposure to this, huh?